Presenting a case of deviated nasal septum to right side with compensatory hypertrophy of the inferior turbinate on the left side. This patient present to me with right-sided gross DNS of the right side, in which anterior region there is ridge from the inferior septum. That inferior septum is inhibiting to pass the endoscope from the inferior meatus. So this endoscope cannot pass on the right side, while the left side there is hypertrophy of the inferior terminate. So this patient present with bilateral nasal blockage on both sides. You can see this right side, this ridge is impinging on the left terminate. You can see this endoscopic picture, and endoscope could not pass from this side, from this depth. So this patient required endoscopic septoplasty and left inferior turbinate turbinoplasty or turbinate reduction. So my plan is to do the limited septum incision on the right side and remove this ridge from this incision. I am putting the incision first horizontal, then convert it vertical at the mucopericardium junction. So after elevating this incision, I will remove this deviated part of the septum. This septum having both cartilaginous ridge as well as bony ridge. On left side, I will do the inferior turbinate incision turbinoplasty after cauterizing the inferior turbinate with the bipolar cautery. I will cauterize the inferior turbinate artery cauterization. So this case represent ideal turbinoplasty with limited septum incision septoplasty. Now question comes, structural defect which lead to nasal obstruction. There are three structural defects which can lead to nasal obstruction. First is the nasal wall. It may be external or internal nasal wall may lead to obstruction. These wall can be ruled out by doing Cottle or modified Cottle test. Cottle test done for the external nasal wall. That area is the nasal cell with the lower border of lateral cartilage. Lower lateral cartilage is the external nasal wall area. You can check by just pulling the cheek laterally. That will open up. That is called Cottle test. Or modified Cottle test mainly done for internal nasal wall. You can also do it for the external nasal wall. You put the probe on the level of lower lateral cartilage, lower border. You can check the external nasal wall. If you are putting this probe on the head of the inferior turbinate and lateralizing it, then this area is the internal nasal wall area. What is internal nasal wall area? Head of the inferior turbinate with the septum and lower border of the upper lateral cartilage. This area is called internal nasal wall area. By doing modified Cottle test endoscopically, you can check both external or internal nasal wall area. Just you have to select the probe area where you are putting. If you are putting on the lower lateral cartilage, then it is you are checking the external nasal wall. If you are putting on the lower border of upper lateral cartilage or head of the inferior turbinate, then it is the internal nasal wall area. Now, second structural defect are the inferior turbinate hypertrophy or concha bullosa. Here is in inferior turbinate, it is two type, bony or mucosal. If mucosal type is there, you can do decongestion test. After giving Otrivin nasal drop, you can redo the nasal endoscopy after 5 minutes. You will check there will be shrinkage of the inferior turbinate. That is called decongestion test. and this is a sign of mucosal hypertrophy. For bony hypertrophy, if you are doing decongestant, there is little bit space is opening, but complete area is not opening, then it is bony. Another test for indeterminate mucosal or bony hypertrophy, you can do CT scan and you can clearly identify there is mucosal or bony hypertrophy is there. And middle terminate, if there is pneumatization or hypertrophy of the head of the middle terminate, then it is called concha bullosa. Then you can address it by opening, just elevating the flap. So this is the second pathology for the structural defect. And third one is the deviation of the nasal septum. It may be bony or it may be cartilaginous. So these three structural defects you can address endoscopically. Now question comes, if there is no pathology and patient having allergy, in allergic rhinitis cases or allergic cases of nose, in whom you will address the septum. So first is, if patient having nasal obstruction even after maximum medication of allergy, then it is a case of surgical intervention. Second one, if there is nasal obstruction is more than the sneezing episode, then it is also a case of endoscopic correction of the septum. So these two clinical criteria can judge that this patient required nasal correction. And third one is CT scan finding. If you are seeing gross DNS or deviation of the septum, then you can address the nose in allergic rhinitis cases. And patient whom they want some reduction in the sneezing, you can simultaneously add the lateral nasal nerve area also with septoplasty. That will decrease the episode of the this sneezing by addressing the posterior nasal nerve, that is called selective neurectomy. By doing so, there will be definitely decrease in the nasal congestion as well as sneezing. This posterior nasal neurectomy is a nerve sparing endoscopic procedure. It is mainly done for medically refractory allergic rhinitis cases or vasomotor rhinitis cases. It is selectively interrupting the supply of postganglionic parasympathetic fiber, in which you are bipolar or coagulator can be used to just cauterize the mucosa between the middle terminate and the inferior terminate. This posterior area just below the spinopalatine foramen. You can put this coagulator vent and just cauterize that mucosa. It is sufficient to do the posterior nasal neurectomy. This nerve arises from the pterygopalatine ganglia and enter the nasal cavity through the spinopalatine foramen, accompanying with spinopalatine artery. And that nerve distributed through this area into inferior, superior, or middle terminate. And main indication are persistent allergic rhinitis despite maximum medical therapy, vasomotor rhinitis, severe rhinorrhea, sneezing, nasal itching, and patient having rhinorrhea even though long-term medication. These cases are ideal for posterior nasal neurectomy. As this case I am operating, it does not have any allergic symptom. That is only having nasal obstruction. That's why I am doing in this case only septoplasty as well as inferior terminate hypertrophy reduction, that is turbinoplasty. So this case does not require any posterior nasal nerve resection. After removing the septum part, I am putting the Vical 30 suture that will take care of this flap or fix this flap. So there will be less post-operative bleeding while you are removing the pack on second day. Now, complications of septoplasty. First is intraoperative complication. It may be bleeding, mucosal tear, septal perforation, injury to upper lateral cartilage, cubiform plate injury may lead to CSF leak, and orbital injury that is rarely seen in septoplasty. Second complication is early postoperative complication. Within days or week, that may be epistaxis, septal hematoma, septal abscess, infection, crusting, synechia formation, persistent nasal obstruction, pain and edema. Now, third one are the late complication. These are septal perforation, saddle nose deformity if you are removing the dorsal or anterior inferior most part, columellar retraction, residual or recurrent septal deviation, external nasal deformity, persistent nasal obstruction, empty nose syndrome, in which case you are resecting most of the inferior turbinate, not preserving the inferior turbinate mucosa or not preserving the inferior turbinate. Hyposmia, anosmia may be there. If you are addressing the high septum, dental numbness due to injury to nasopalatal nerve, chronic dryness, crusting, or whistling sound if there is perforation is there. That may be because of anterior portion of the septum perforation. Rare but serious complications are CSF leak, meningitis, toxic shock syndrome, orbital hematoma, visual loss, intracranial injury, or cavernous sinus thrombosis. These are the complication of the septoplasty. Now, you see, I am addressing the inferior turbinate by putting the incision on the inferior most border of the inferior turbinate and making a flap, and then I will remove the bone and reposition this flap back, and there will be no defect or no large gap. There will be ideally you will see if I reposition these flap back, you will see only line, and this is the ideal method which Dr. Richard Harvey is following. After cauterizing the inferior turbinate artery, you will not face any bleeding from this. Now you can see I will remove this bone, and this is the ideal and long term effect of this inferior turbinate turbinoplasty. So you follow this, and this is the ideal method to do the inferior turbinate reduction.